So I'm going to talk to you today about drug-induced interstitial lung disease in patients with rheumatic disease. Methotrexate is the most commonly prescribed drug by rheumatologists. It's our first-line drug for early rheumatoid arthritis, and I recently looked at my follow-up patients, and 1 in 3 are on methotrexate. Methotrexate is the most commonly prescribed drug of all drugs associated with interstitial lung disease, which is why a rheumatologist is talking to you about it today. So this is a case from our unit, a 70-year-old lady who presented with an inflammatory arthritis affecting the small joints of the hands and feet. She was known to suffer from psoriasis. She had mild raised inflammatory bloods, normal chest x-ray, satisfactory spirometry, and was started on 10 milligrams of methotrexate weekly and folic acid 5 milligrams weekly. After 8 weeks, she contacted the nurses' helpline. She'd developed acute progressive shortness of breath and a dry cough. An urgent clinical assessment was made with the medical staff. They had a full assessment, a chest x-ray, the methotrexate was stopped, and an urgent chest high-resolution CT scan was requested. This is the CT scan, and what you're seeing are zones of ground glass change, and you're seeing that in all zones of the lung. When she was reviewed with the results of the CT scan, she was very much better, so we didn't need to do anything else at that point. We did repeat the CT scan, and here you can see the dramatic improvement on withdrawal of the drug in keeping with a methotrexate pneumonitis. So the outcome for this patient was good, but you'll probably remember 10 years back when people died from methotrexate pneumonitis, and the fatality rate is between 10 and 20%. And if you re-challenge someone who's had methotrexate pneumonitis, the mortality rate is even higher at 25%, and I wouldn't recommend you do that. There's criteria to help you diagnose methotrexate pneumonitis, and in that respect, Searles and McKendry criteria are the most useful. So you have this acute onset of shortness of breath. Classically, it's 6 weeks after starting the methotrexate, and the vast majority are in the first 6 months of starting methotrexate. There's systemic ill health with a fever, an increased respiratory rate, and typically a non-productive cough. The white cell count is raised, but it shouldn't be above 15 times 10 to the 9 per litre. And in half the cases you'll see eosinophilia in the blood film. There's hypoxia, and it's obligatory to exclude infection with the appropriate cultures. We're expecting to see on imaging interstitial infiltrates. You may not see that on the initial chest x-ray, as with that patient it might be on the high-res CT scan. If the patient's well enough to do pulmonary function tests, and if they have the other criteria they're not, then you'd see volume loss with a restrictive pattern and a reduced transfer factor. And if you have histology, then you expect to see bronchiolitis, interstitial pneumonitis. You may see giant cells, and sometimes they form granuloma. In severe cases, often associated with fatalities, you get diffuse alveolar damage, and of course there should be no evidence of pathogenic organisms. You're wanting at least 6 of those criteria to be coming close to the diagnosis. Once you know that presentation, recent introduction of methotrexate, progressive shortness of breath, interstitial alveolar infiltrates, systemic ill health, use the Carson's criteria, particularly if you've got a rheumatoid arthritis patient. So point 1 is that clinical hypersensitivity reaction. Point 2, exclude infection. You also need to exclude other pulmonary disease. And with rheumatoid arthritis, we know 20% have interstitial lung disease. So we need that arranging. Then you need one other factor, either that dramatic resolution of your interstitial shadowing. You never get that when they have underlying pulmonary fibrosis. Or if they don't survive, then histopathology in keeping with a pneumonitis, as I described before. How common is methotrexate pneumonitis? Well, there's 24 studies that have looked into this, and they've predominantly used the Searles and McKendry criteria, and very few have used CT scanning. The range is between 0.3% and 18%, with an average of 5%. And you can see it's dropping with time. And we did a 6-year study on patients commencing methotrexate therapy, followed them up for at least 6 months to see if they developed methotrexate pneumonitis. We were using methotrexate up to doses of 30 milligrams. Our prevalence in over 200 patients was only 1%. So we have a rare but potentially fatal side effect. It'd be really good if we could predict who's going to develop methotrexate pneumonitis. And a number of studies have looked into that. However, the quality of these studies does depend on the sample size and the criteria used for methotrexate pneumonitis. There's some consistency through the studies that older age increases your risk of methotrexate pneumonitis. In the older studies, where we were using lots of drugs and not necessarily methotrexate first line, then previous DMARD use increase your risk. Diabetes was shown in one study but not reproduced in any others. And then there's this question about pre-existing lung disease. Of all types of lung disease on a chest x-ray, it has been associated, and also with interstitial shadowing, and also with a reduced transfer factor. But in that study, they didn't actually show chest x-ray changes predicted methotrexate pneumonitis. We then had a 10-year hiatus in looking into this, and now we've started looking at HLA typing and hypersensitivity reactions. There's an association between a skin hypersensitivity reaction and HLA. So a Japanese group looked at methotrexate pulmonary events and HLA typing. They found a statistical significance, but not a clinically useful significance. So there's been a UK trial via the CLRN looking at carefully defined methotrexate pneumonitis and genetics, and hopefully those results will be through soon. What's our approach to methotrexate? We use it first line. We do a chest x-ray to look for pulmonary disease. We do a spirometry, and we're looking for FEV1, FVC of over a litre. I'm not saying that's normal, but what I'm saying is if they get pneumonitis, we know that and we get them early, they're likely to survive it. We invest a lot in education. They have half an hour education before they start methotrexate, explaining all the potential side effects, including shortness of breath and what to do if that happens. We use CT scanning, and we know who our experts are in interpreting that, and we use Carson's criteria to make the diagnosis. With that approach, we've had no fatalities from methotrexate pneumonitis. Nice guidance came in for the management of rheumatoid arthritis, and in essence, from all the good evidence, it said, try and get your patients on a DMARD, ideally methotrexate, within 6 weeks of the referral from the GP in anyone with suspected early rheumatoid arthritis. So I looked again to see, is our management interfering with that? And we've had over 200 patients go through our early arthritis clinic. 93% start methotrexate as first-line therapy. Then we have 7% who didn't. 7 of those, it was pretty much down to personal choice. And then we had 12 for pulmonary reasons. Only 2 was it because the FEV1 was less than a litre. And that was in your COPD group. And really we avoided methotrexate in symptomatic COPD because they were repeatedly short of breath. How would we know if it was methotrexate or COPD? We'd keep on stopping it. So we pragmatically chose a different drug. 2 had pulmonary fibrosis, confirmed on CT, which you would expect that sort of prevalence in early RA. And then we had a couple with lung shadows that needed sorting out, so they went on a different drug. We had no cases of methotrexate pneumonitis this time. So it's getting rarer, and we've changed our approach to spirometry. And if you have limited access, this is the group I would pick out. So you're really looking for those who aren't going to survive a methotrexate pneumonitis. So we're thinking, check the spirometry if they have known pulmonary disease, if they're smokers or age 65. As you get older, your FEV1 drops off. And if they're abnormal, we'll investigate, quite possibly with a CT if they've got restricted defects, before we refer on to anyone. Now, to my mind, there's a very contentious issue. Does methotrexate cause chronic pulmonary fibrosis? And when you look at the literature, it's down to terminology. There's very little evidence to support it. And back in 2002, I studied this. And with the funding from the British Lung Foundation, I CT scanned 150 rheumatoid arthritis patients looking for pulmonary fibrosis. This is very different to the scan I just showed you before. We've got apicobasal predominance of reticular change, all these lines. We've got honeycombing, which is your hallmark really of usual interstitial pneumonia. So this looks very different, behaves very differently. So I was looking for that in the rheumatoid group, and we had 55 patients on methotrexate and 73 treated with alternative DMARDs, and I followed those up for 2 years. They've had a few years of therapy, so we're not surprisingly, I didn't see any methotrexate pneumonitis in this group. There was no difference between methotrexate and the control group on CT scanning, whether they had pulmonary fibrosis or not. I looked at the dosages, didn't make any difference whether they had pulmonary fibrosis or not. A couple of patients had both reticular change and ground glass change, and I stopped the methotrexate. Didn't help at all. I followed them up for 2 years. There was no difference in the progression of their lung disease. So I found no evidence of pulmonary fibrosis being related to methotrexate. I have to say there were fatalities in the pulmonary fibrosis group, but they were all in the control group, not in the methotrexate group. The literature supports this. There's a website, Pneumatox, and you can have an app for your smartphone, and it's very useful. And this records all the worldwide peer-reviewed publications on lung disease related to medications. Not just rheumatology medications, all medications, and not just interstitial lung disease, all types of lung disease. And they give you a star rating according to how many publications there have been. Now I've changed it into colours so you can see it. So if there's over 200 cases, that's a red, and if you're at less than 10, you're on a yellow. And you can see methotrexate fits both boxes there. So pneumonitis, no doubt, highest drug associated with pneumonitis. Very rarely are there publications on pulmonary fibrosis. All types of anti-TNF therapy are associated with interstitial lung disease, and I'll talk about that later. Leflunomide is another interesting tale that I'll cover in a moment. Rituximab, when used in haematology regimes, then you do get a pneumonitis. So 95% of the reports are of pneumonitis associated with the haematology high-dose regimes. Very rare that it's associated with exacerbations of pulmonary fibrosis. Back in the day, when we used gold, it was associated with interstitial lung disease, and they've picked up those reports. And then we've got a few reports related to azathioprine, sulfasalazine, mycophenolate, and more recently tocilizumab. There are no reports related to cyclosporin or mycophenolate in interstitial lung disease. Abatacept, there's an abstract report, but this doesn't pick up abstracts, so abatacept isn't picked up by this. Leflunomide is interesting. It was brought out when we knew methotrexate was a really good drug for rheumatoid arthritis, and it was promoted with, if you're worried about the lungs, why don't you give them leflunomide, it's just as good. And some people did that. In the trials it looked perfectly safe, there was no safety signals, but in Japan and Korea they had an outbreak of ILD, and 1.1% is an outbreak of ILD in my world. This was compared to the European studies where only 0.02% were found to have had ILD. So this highlights the ethnic variation in pneumonitis. The presentation of leflunomide pneumonitis is just the same as methotrexate pneumonitis. Systemically unwell, progressive shortness of breath, interstitial alveolar infiltrates occurring within 20 weeks of starting the treatment. Similar mortality at 18%. This was in the era of CT scanning, so they were able to find that interstitial lung disease did increase your risk of pneumonitis with a relative risk of 2.6. Moving on to anti-TNF therapy, all types of anti-TNF have been associated with reports of interstitial lung disease. They're either reported as the hypersensitivity pneumonitis reaction, as we see with methotrexate and leflunomide, or with exacerbation of pulmonary fibrosis. Systematic literature reviews that I've put up combine the two together. So there's plenty of reports. There is no doubt they're associated with both pneumonitis and exacerbation of interstitial lung disease. The average time to them occurring after starting biologic is 26 weeks. And most worrying is the mortality rate, which is 32%. But you have to remember they're taking the mortality rate of an acute exacerbation of pulmonary fibrosis, and that's between 30 and 100% in anyone. But is that just the underlying rheumatoid disease? Is it any worse than the other drugs? You need to look at control groups. So these are the studies where anti-TNF has been compared to control groups. The first one was by Fred Wolf from the States, looking at patients hospitalised with interstitial lung disease and rheumatoid arthritis and which DMARD they were on. He had 100 patients that had been hospitalised, found no association between the infliximab and etanercept, which were the anti-TNF agents at that time, and DMARD used, just with the predisposition to interstitial lung disease and the use of corticosteroids, which is no surprise to us now. There was a study where they were looking to see if etanercept, one of our first anti-TNF agents, was a treatment for idiopathic pulmonary fibrosis. And when you have usual interstitial pneumonia in rheumatoid arthritis-associated lung disease, which you have in about 80% of cases, it's very, very similar to the idiopathic pulmonary fibrosis in its behaviour. They did it in idiopathic, not in rheumatoid-associated. They found no benefit, but equally they found no harm using it. Then we have the largest data, which comes from the British Society of Rheumatology's Biologics register. So patients starting biologics, anti-TNF therapy, rituximab, tocilizumab, have been put into a registry and followed up to find out what events happen to them. And there's also a control group of rheumatoid arthritis patients. 367 patients is a lot in the interstitial lung disease research world. And they looked at mortality. And if you have interstitial lung disease associated with RA, you have a higher mortality than having RA alone. They found no difference between the control group and the biologics group in terms of overall mortality. But when they looked at what was the cause of death on the death certificates in the anti-TNF group, it was 3 times more likely to be due to interstitial lung disease than in the control group. And finally, there's a study looking at development of interstitial lung disease after people have started anti-TNF therapy or your non-biologic disease-modifying therapy. 38 out of 8,417 developed interstitial lung disease. And this is helpful. There's no difference between the DMARDs and anti-TNF with those sorts of numbers, but it is giving you a prevalence that your anti-TNF is associated with 0.5% interstitial lung disease occurrence. Just to talk about pulmonary fibrosis, if you've sat in an interstitial lung disease clinic, you probably discover it's one of the hardest clinics to decide when to treat a patient. The progression is not linear, as you see in many conditions, although it's rarely linear. What we tend to see are these stepwise progressions where you have periods of stability, could be a year or more, and acute exacerbations. So you get this stepwise progression. Collaboration has now occurred to define what is an acute exacerbation of pulmonary fibrosis, and that's a deterioration in 30 days or less, unilateral or bilateral ground glass change on established pulmonary fibrosis change, and no other cause for acute lung injury such as PE or pancreatitis. So now we've defined an acute exacerbation, we can work to find out what is the cause of acute exacerbation. We don't know as yet, but there's one theory that it's a cult infection that triggers an ARDS on top of the pulmonary fibrosis that causes that major deterioration. We don't know what that infection is, but exacerbations of interstitial lung disease are quite seasonal, which tends to point to viruses doing it. We know traction bronchiectasis associated with pulmonary fibrosis has a poor prognosis. Is it the bacteria in those bronchiectatic areas that's triggering it? And then we have the immunosuppressed connective tissue rheumatoid groups. Is it the atypical infections that are doing that? And there is a study from Japan that's pertinent to that, looking at rheumatoid patients on biologics, both anti-TNF therapy and tocilizumab, And these patients had developed diffuse ground glass change on their imaging. And they tested them for pneumocystis serology. 22 out of 25 came back positive, and the patients responded to treatment for that. Guidance has come out nationally on what to do with patients who have interstitial lung disease and you're about to start anti-TNF therapy. The first to come out with guidance was our own British Society of Rheumatology, and they said, give them anti-TNF, but make sure you monitor them, and if they develop interstitial lung disease or it progresses, then stop the anti-TNF therapy. The French equivalent group, a year later, took a different view. There's so many biologics, why give anti-TNF to someone with interstitial lung disease? But if you are going to do it, monitor them. Again, stop the biologic if they develop ILD or it progresses. There's an excellent publication that I urge you to read by Fiona Lake that came out in 2014 that gives a whole overview of all aspects of rheumatoid-associated lung disease and medications. And she puts all the evidence together very well. Interstitial lung disease associated with TNF therapy is 0.5%. It's rare. Subclinical interstitial lung disease associated with RA is common. Many of these patients will benefit from anti-TNF. Let them have it. But don't give it those that have significant interstitial lung disease, poor pulmonary reserve and comorbidities. If you are going to give it, remember to monitor. Remember that the average presentation is 26 weeks after starting your biologic, predominantly anti-TNF, so monitor carefully in the first year, 3 to 6 monthly. What should we give them if we're not going to give them anti-TNF? Well, this is some data that was presented at the British Society of Rheumatology 12 months ago. And as a group of rheumatologists and a small group of chest physicians that have an interest in rheumatoid-associated interstitial lung disease, and we've all put our databases together of our patients and all their clinical features. And there's a control group that we've taken with rheumatoid without interstitial lung disease and compared them to them. Now you can see, if you're looking at all-cause mortality, that you have the controls, and as seen in the Biologics registry, you have a higher all-cause mortality in rheumatoid-associated interstitial lung disease, even a little higher in the anti-TNF group. If we're looking at respiratory mortality, we see again anti-TNF worse respiratory mortality than your patients treated with control DMARDs or your control RA patients. But look at rituximab and their respiratory mortality. That is matching your control rheumatoid groups, and that's despite the patients being older and the interstitial lung disease, more of it being UIP. And we know from connective tissue disease that rituximab has been seen as a useful treatment for interstitial lung disease. So in summary, pneumonitis is a rare complication of our therapies. In methotrexate, it's up to 1% of patients starting this treatment. It's lower with the other DMARDs, it's probably 0.5% in the biologics. If you're suspicious of pneumonitis, the best thing you can do for your patient is to stop the methotrexate early. Do arrange a CT scan to see if you get that characteristic all-zone ground glass change, but acknowledge you can't possibly make the diagnosis until you've excluded all other cause and you've seen that resolution of infiltrates on withdrawing the drug, so we as rheumatologists can go back to using the drug after the event. Pneumonitis is rare and it's idiosyncratic. We can't yet explain who's going to get this. It is more common in the elderly, the cut-off being, I can't give it you from the rheumatoid trials, but if we're looking at other trials, over 65 is the worrying age. Pre-existing respiratory disease is a risk factor. We don't exactly know if it's a specific one from the rheumatoid data. If we look at lung chemotherapy, that causes a pneumonitis, and you have CT scans pre and post treatment with them. They're excellent studies, the best there are on pneumonitis. Yes, it's interstitial lung disease, but it's also lung volume loss to whatever cause. So if you've had half a lung out, If you've got very severe emphysema and you've lost lung, then those are your risk factors. And then there's this ethnic variation in pneumonitis that we're hoping to explain with HLA typing soon. But at the moment, I can't tell you who's going to develop pneumonitis. So I'd suggest you do spirometry on those that could have pulmonary disease and a low FEV1, the over 65s, smokers, and those known to have lung disease. Assume anyone can have this complication. So particularly with methotrexate, educate them before they go on the drug, what to do if they develop shortness of breath, because it occurs typically at 6 weeks, sometimes sooner. And in patients with RA-associated interstitial lung disease that are going on biologics, I would also educate them. My advice to any rheumatologists in the room: if you know your patient has pulmonary fibrosis associated with rheumatoid arthritis, the first thing you should do is go down to your radiology department, find your radiologist who knows most about interstitial lung disease and say, is this UIP pattern interstitial lung disease? That's the one with the poor prognosis where you get the acute exacerbations. Once he's answered that question, ask him how much of the lung is involved. 25% or more is significant pulmonary fibrosis. That's the group that progress and do very badly. And if you've got UIP over 25%, then I'd treat them with rituximab if that's the disease activity and they've got that level of lung disease. Less than 20%, if they're asymptomatic, they're under 65, good respiratory reserve, I'd give them whatever biologic you think is going to work for them. If they're symptomatic with a lesser degree of interstitial lung disease, or they're having traction bronchiectasis, they're over 65, go back to rituximab. With all of them, educate them to look out for shortness of breath as a deterioration in their interstitial lung disease, and make sure there's a way for them to present early to you. I'd say monitor them 3 monthly for the first year. Probably your first monitoring visit is just to reinforce, tell me if you get out of breath. Those acute exacerbations are unpredictable. You're not going to pick them up necessarily early on expecting the pulmonary function test to drop off, but you want to be able for them to tell you they're out of breath. Once they get to a year, if they've not had an exacerbation, move them to 6 monthly or 12 monthly monitoring. In a similar way to what Janice was describing with vasculitis treatment, the biggest cause of death is infections in this group. We've got to do everything to try and prevent infection. So we want yearly influenza vaccinations, 5 yearly pneumococcal. We want steroids to be avoided and withdrawn. Combining biologics with steroids really increases your infection risk. There's a study looking at rheumatoid patients, high risk for pneumocystis, patients over 65 with interstitial lung disease with steroids. 2 out of 3, they gave them pneumocystis prophylaxis, got rid of all those infections. So you should consider that if your patient isn't on methotrexate. My advice to the physicians in the room in the medical assessment unit: so if you're sitting there and you're alerted to a patient coming in with short of breath, with a fever, with a rheumatic disease, maybe rheumatoid, but we use the biologics and psoriatic arthritis, ankylosing spondylitis and connective tissue disease. First of all, ask them, are they on a biologic? We've just done an audit of patients admitted to hospital on biologics because we have a computerised alert system every time a patient comes in. Only 1/3 of medical clerkings recorded initially whether the patient was receiving a biologic or not, and they were all on them. So you need to ask them, and you need to ask them when was it started. The most likely cause of admission is infection in this group, so do assess for that and treat appropriately. But remember the atypical infections, pneumocystis, Legionella and TB, which are increased with these immunosuppressants. If that patient who's short of breath with a temperature with rheumatoid has a white cell count of less than 15, a touch of eosinophilia, and has started their methotrexate or their anti-TNF within 6 months, start thinking pneumonitis. The chest x-ray may be clear if it's early, or you may have interstitial shadowing, in which case I'll be stopping the drug, telling the rheumatologist, and I'd be getting an urgent CT scan. When I got that CT scan, I'd be going to see the radiologist to confirm or not whether there was a pneumonitis pattern there. In poorly patients, then you can give them high-dose steroids. There's a few case reports showing that that's been beneficial. They may need intensive care support. A bronchoscopy is useful in that situation, so you can lavage for pneumocystis and you can get a cell count if they're stable enough, and that can help differentiate interstitial lung disease related to RA and pneumonitis. But remember, you can't diagnose your pneumonitis conclusively until the end of the illness, when you've excluded all other causes of respiratory presentation and you've seen that dramatic improvement on withdrawal of the drug in the infiltrates on the X-ray, or you have histopathology to confirm that. And finally, I realise now it's coming up to 20 years that I've been researching into this subject. Initially that was with funding from the British Lung Foundation, but overall it's been with terrific support from my colleagues at St Helens and Knowsley hospitals. So I'd like to thank the radiology department, the respiratory department, and most of all the rheumatology department for all their help and support over the years. Thank you.